Hello and welcome to the Clinical Care Options podcast series. I'm your host, Zachary Schwartz. In this podcast, we discuss how to manage primary biliary cholangitis in someone with cirrhosis. Should their treatment goals be the same as someone without cirrhosis? What treatments should we use? To discuss these questions, I'm joined by Dr. Nancy Reau at Rush Medical College and Dr. Stuart Gordon from Wayne State University. For more information, including slides you can use to follow along with this podcast, please see the show notes. Now let's get started.
Well, hello and welcome to this Curbside consult. In this case, we explore the management of PBC therapy for patients with cirrhosis. I am Stuart Gordon, hepatologist at Henry Ford Health in Detroit.
Hi, and I'm Nancy Reau from Rush University Medical Center in Chicago.
Let's start off with a patient case. This is a 60-year-old woman with abnormal LFTs, pruritus, and fatigue. You can see here she has bilirubin of 1.2, AST, ALT 125, 139, alpha 658. Her mitochondrial antibody is positive, as is her anti-nuclear antibody. She has a FibroScan transient elastography score of 21 and a nodular appearing liver ultrasound. So we have a cirrhotic individual here. She was started on weight-based urso by her local gastroenterologist. 6 months later, her symptoms are unchanged. Her LFTs are still raised, and she still has mild pruritus that's not responding to cholestyramine. Her bilirubin, AST, ALT, and alphas have all come down a bit, but they remain raised. So at this point, we sort of ask ourselves, first off, what is this? Is this standard PBC, or is this perhaps autoimmune crossover? And what is the significance of a positive ANA? Nancy, you want to lead off?
Yeah, I think that we have a lot of anxiety about missing crossover autoimmune with PBC, but in reality, that's a pretty uncommon thing. And immune disorders, like most immune disorders, PBC does frequently have an anti-nuclear antibody that's positive. And I don't think that that alone is good enough trigger for us to label someone as a crossover or combined AIH PBC. This patient has actually done an excellent job in improving her ALT, AST while on ursodeoxycholic acid, which I think is a little unusual. I think usually in my practice, if I'm worried about overlap, I would then proceed with a liver biopsy because I don't want to start someone on immune modulation if it's not really warranted. Is that what you do also, Stuart?
It is. And there, if you look at the guidance document, very specific parameters by which we would consider crossover. These would include transferase elevations of over 5 times upper limits of normal, which we didn't deal with here, markedly raised IgG, or, for example, liver biopsy. But I think for practical purposes, many patients with PBC can have a positive ANA, and it doesn't really change the diagnosis. So I think we're dealing with fairly classic PBC in this case. How about the presence of cirrhosis? Does this affect how you're going to be approaching this patient?
Yeah, we always know that our therapy is generally meant to decrease the risk of decompensation, to decrease the risk of liver cancer, decrease the need for liver transplantation. And I think if you are starting closer to this endpoint, you're going to be, I wouldn't say more aggressive. You're going to start with standard therapy either way, but I would worry about, meeting those goalposts because our patient really does have a high risk of developing liver-related complications. That doesn't mean that I suddenly decide that the patient's failing what we're doing at an earlier time point, but I'm probably not going to be comfortable watching this person for a long period before I decide that treatment is efficacious.
I would agree entirely. And we'll look at some data coming up here on presence of cirrhosis in patients with PBC. How about how frequently we check the ATs? This is a common question in the clinic. We've looked at our real practice, and we'll be talking about this a little bit more. How often we've gotten the 6-month mark? How frequently do you check the liver parameters and others while on urso?
So I don't know about you, but when I start a person on ursodeoxycholic acid, it's not always well tolerated. So I might start them at a lower dose and then try to move them up over the next 2, 3, 4 weeks to ideal weight-based dosing. And when you're doing that, understanding that you may not even meet the full dose for the first month or two, you're not going to decide efficacy at that time point. You really want a little bit of time to go by. And so I usually don't check my liver enzymes for about 3 months after I start, unless my patient is complaining that they're not doing well or they're having complications. And then, you don't want to miss drug-induced liver injury, which is very, very, very uncommon with ursodeoxycholic acid. But at that point, I might check things a little sooner.
Yeah, that pretty much mirrors what I do. I thought I was the only one who started off low, but I mean, it's true. I often start off at just one a day and just say, just ease yourself into this and just check them after they've achieved weight-based dosing. All right, well, what would we do next if this patient? We got 6 months, they haven't met response criteria. What would you recommend next?
Well, I think that these questions are never 100%, there's never a perfect right or wrong answer. So that if I knew that my patient really took a little bit of time to get to full dose, or if they had missed some doses, or they were very hesitant to add another medication because they were worried about polypharmacy, I think that I could go another 3 to 6 months before adding or talking about another agent. But like we started this case, this person has compensated cirrhosis, and the goal is to not let them progress. I think at this point, I would probably be starting to talk about a second agent in this individual, even if they weren't ready to start right away, really starting that conversation to be, you're not where we want you to be. These are the strategies to potentially get you there.
So, what are your thoughts regarding guidelines recommendations to wait 12 months before considering second line therapy? This is a question that comes up in the clinics all the time. And simultaneous with that, does the presence of cirrhosis in this particular patient impact your decision of when to use second line therapy? And in particular, what about the presence of this patient's pruritus and fatigue? Nancy, what are your thoughts?
Yeah, I mean, I think it's important to remember that guidelines are evidence-based, and we have had a lot of motion in therapeutic options as well as what your goals are in PBC. And so it's going to take a little time for these new concepts to make it into our guidelines. And now that we know that normal is better than abnormal, and we kind of are looking at when to expect your therapies to plateau. I think many of us are using a 6 month mark as opposed to a 12-month mark in our patients, especially those that are higher risk or those that might have extra hepatic manifestations. Our guidelines also were written at a time where we didn't have a lot of therapeutic options. We were using things, off label like fibrates, knowing that the data on fibrates, as we'll kind of dive into, really concentrated on a fibrate we didn't have access to in the United States. And now knowing that we have two new PPARs and that we have some additional safety and efficacy and long-term data on abetacholic acid, it really gives us the ability to reevaluate efficacy at a sooner time point.
All right, good. These are my thoughts as well. And in particular, when we talk a little bit about treating symptoms of pruritus, well, this was one study that I thought was really very interesting, which is looking at UDCA response associated with a decreased morbidity and mortality in PBC patients with compensated cirrhosis. This was a large VA study, a retrospective analysis looking at approximately 500 patients. And as you can see here, after adjusting for all potential confounders, UDCA response was associated with a significant reduction in all-cause mortality or transplantation. So these are nice Kaplan-Meier curves showing the importance of treatment in the cirrhotic patient and the long-term clinical benefits that can be achieved. What about if the patient, had varices, for example, or a little bit of ascites, or dropping albumin or higher bilirubin? What about these different options that are available to us? And how do we sort of classify patients as compensated versus decompensated? Lots of questions that are being raised now, especially in the cirrhotic population.
Yeah, so I think my view has definitely evolved. When we only had abetacholic acid as a approved second line agent, and before some of the safety data really was more granular around this, I would have started abetacholic acid in a well-compensated cirrhotic and might have a little bit of hesitancy if there was signs of portal hypertension, like you're talking about, varices that haven't bled, or a little lower extremity edema, or that mild decrease in your albumin or a mild increase in your bilirubin, really suggesting that although compensated, this is someone that is closer to decompensating than someone who is like just barely, very early cirrhotic. And then we moved to a time point we realized that abetacholic acid might increase toxicity. And so we were doing weekly dosing But now that we have better options in a person who had suggestions that they might be at risk for more advanced disease, I would start one of the new PPARs and probably avoid abetagolic acid and would avoid off-label fibrates. I mean, in the package insert for fenofibrate, which is what we have available to us, there's a clear hesitancy around using this in a patient population that has cirrhosis.
These are my thoughts exactly. And this type of case raises some important clinical issues in terms of how we define our cirrhotics, because there's so many different parameters that can affect whether we call them, a child's A or a child's B, for example. But we're really talking about stable cirrhotic patients here that we want to discuss some of the newer PPARs. So in terms of second-line treatment of PBC, fenofibrate is really off-label in this setting and is not recommended for those patients with more advanced fibrosis. So we probably would not want to be using fibrates in this situation. OCA was first approved in 2016 and is probably, and we'll go into some of the details, not the best to be used in cirrhotics at this point. So there were certain precautions that were raised for patients with cirrhosis, as again, not recommended for those with decompensation. In 2022, the AASLD recommended that its use in patients with cirrhosis require more careful monitoring. And in 2024, the FDA noted there are some patients, even without cirrhosis, who may have serious liver injury and to monitor liver tests often for identification of any worsening of liver function. Elafibranor and seladelpar, which were approved in mid-2024, has some data in cirrhotic patients, and we'll be going over some of that. All of these agents are either contraindicated or not recommended in Child-Pugh B or Child-Pugh C cirrhotics. Important point. There is some data looking at both of these new PPAR agonists in patients with advanced stage PBC. In the phase 3 elative trial, in patients with PBC not responding or intolerant to UDCA, advanced fibrosis was defined as liver stiffness or transient elastography scores of greater than 10 kilopascals or histology among those patients who had liver biopsies. And there were similar biochemical responses among those patients with advanced fibrosis and similar responses among alkaline phosphatase normalization among those with advanced liver disease. Here we see the relatively prompt reduction in alkaline phosphatase over time among those patients with advanced stage disease compared to placebo. And really looking at advanced stage disease versus early stage disease, we still see rather prompt alkaline phosphatase reductions over time among those patients with advanced fibrosis and PBC. In terms of safety data, the subset of patients receiving elafibranor with advanced fibrosis was similar to that in the overall population, 17% versus 15.8% placebo, and 3 patients with discontinuation among those with advanced fibrosis in the elafibranor. Now looking at the ASSURE trial, which is looking at seladelpar in patients with PBC and cirrhosis. These were more defined cirrhosis by certain parameters to establish the diagnosis of cirrhosis. And this was the phase 3 trial and the legacy group part in phase 1, who then moved on into the ASSURE trial. And this is looking at going all the way up to those patients who made it up to month 24. These are the biochemical responses among patients with cirrhosis, and similarly impressive alkaline phosphatase normalizations among PBC patients with cirrhosis receiving seladelpar. Here we're looking at the biochemical response among patients with cirrhosis. Again, the alkaline phosphatase reduction was prompt and occurred early on and was generally durable throughout the observation period, less so in terms of the total bilirubin. And here looking at the safety data of seladelpar among patients with PBC and cirrhosis, there were 8 patients who had so-called liver-related adverse events, and these were including aminotransferase elevations, GGTP, a host of events that were designated liver-related, including 2 patients with ascites and 2 patients leading to discontinuation. So I think that we have demonstrated that both of these new PPAR agonists, elafibranor and seladelpar, have demonstrated a comfortable safety margin among patients with PBC and compensated cirrhosis.
This is excellent discussion, and I think that it's really important for us to not be lackadaisical in our cirrhotic patients. They do respond to treatment, And our treatment endpoints should be similar in our cirrhotics as our non-cirrhotics. So if you have someone who's not met biochemical remission after 6 to 12 months, you should be thinking about second-line therapy. Here, though, second-line therapy is a cautionary tale. If you have decompensated cirrhosis, Child B, Child C, none of these agents are really going to be a good fit. This is someone that I think we should be talking about transplant in. But if you are not a decompensated cirrhotic, then our two new second-line PPARs are great options and respond actually pretty quickly. So within the first 3 months, you should be seeing efficacy defined by an improvement in the alkaline phosphatase. That's really exciting for these patients.
It's exciting data. There's additional data showing improvement in itch, which we can talk about at another time as well. But I would agree with you. The cirrhotic patients with PBC can respond very well to these newer PPAR agonists, should definitely be considered. And as we showed from some of the VA data, complete response can translate to improved survival.
Thank you to Dr. Reau and Dr. Gordon, and thank you to our listeners for joining in. To hear more podcasts on PBC, subscribe to the CCO podcast channel on your favorite service.